A 60-year-old lady, Mrs. Lalu Thomas, resident of Kerala and a housewife, came with a complaint of Disney on exertion since last 2 years, aggravated since last 1 month. She had an episode of syncope on July 3rd, 2024, for which CPR was given. After 3 to 5 minutes, she regained consciousness. History of presenting illness. She had dyspnea on exertion since 2 years, initially NIHA class 2, now progressed to
Not
class 3.
not Neha, it is New York Heart Association. Please call it New York Heart Association and not Neha. It's not somebody's name.
Yes, sir.
Hmm.
New York Heart Association class 2, now progressed to class 3, which was relieved by rest. On July 3rd, while climbing stairs in the railway station, she had an episode of syncope followed by loss of consciousness. CPR was initiated by family members. 2 to 3 cycles were given. After that, 3 to 5 minutes, she regained her consciousness and she was transferred to the nearby hospital. After stabilization, she came here for further management. No history of PND.
Does she have any neurological deficit?
No, sir.
No, that is important in the history. Loss of consciousness, the period of loss of consciousness and residual neurological deficit should be brought out in the history.
Yes, sir. No history of PND, no history of angina or palpitation, no history of thromboembolic event, no history of fever on child. Past history. On her regular checkup, she was found to have a valvular heart disease 7 years ago. She was advised to do regular checkup, but she couldn't do that. Instead she reduced her day-to-day activities since last 7 years. Comorbidities. She was a hypertensive since last 25 years, and she was on regular medication. Personal history, non-vegetarian diet, normal bowel and bladder movement, no history of alcohol, smoking or tobacco chewing. Past surgical history, hernia surgery 2013, LSES on 1982 and 1989. Obstetric history P2L2A0. Medication, she was on cilnidipine, 10 mg HS for her hypertension since 25 years.
Go back here to go to your previous slide. See, when you talk about this thing, no history of fever on childhood doesn't mean anything to anybody. No, fever is not one episode in your entire lifetime, right? So either you're trying to rule out history of rheumatic fever, so you must say no history suggestive of rheumatic fever, and that means fever, sore throat, fever, and splitting joint pains. These are the major things that are there. So instead of getting into all that detail, you can just finish off in one sentence: no history suggestive of rheumatic fever in our childhood.
Yes, sir.
Okay, and if the examiner wants to ask you what do you mean by rheumatic fever, then you should say fever, sore throat, fever, and other things. But don't, so your history should be quick, and at the same time you are conveying to the examiner what you are trying to say.
Yes, sir.
Yeah. So when you write your case sheet, you must read it again, edit it, so that you are trying to tell the examiner what you want him to know.
Yes, sir.
Right. Okay. Now, in a 60-year-old lady who has come with a valvular heart disease at 7 years ago, do you think that this patient has rheumatic fever? Rheumatic heart disease? Unlikely.
No, yes.
So, anyway, that you have to see through your physical examination and investigations and other things. So anyway, in the passing, it's all right because it's valvular heart disease. You should say, and it's the commonest thing. No history suggestive of rheumatic fever in the child. Finished. That conveys everything.
Okay, sir.
Oh, okay.
A 69-year-old lady presented with dyspnea on exertion, New York Heart Association class 3, and one episode of syncope with a history of hypertension and on treatment since past 25 years. General physical examination, she is a well-built and nourished. BMI is 27.2 kg per meter square. No pallor, icterus, clubbing, generalized lymphadenopathy, or pedal edema. Vitals, heart rate 76 beats per minute, irregular rhythm. Low volumes,
Excuse me.
low rising pulse with no
Just
radio.
slight in move. Vitals. Go back to vitals. Yeah.
Vitals, heart rate 76 beats per minute, irregular rhythm, low volume, slow rising pulse with no radial delay or radiofemoral delay. All peripheral pulses are felt. BP is 130 by 70 mmHg. Respiratory rate is 16 cycles per minute. JVP is not raised.
Okay, hold on there. I'm going through basics because you are in the second year, So when you say heart rate 76 beats per minute, irregular, generally you're trying to convey that this patient is in AF with a controlled ventricular rate, right? 76 is not a fast ventricular rate. So low volume pulse, instead of saying just low volume, it is better to say varying volume, because in atrial fibrillation the pulse will become of varying volume.
Okay,
If you can appreciate that clinically. If not, it's okay, it's fine. Then again, radial delay or uh, radio femoral delay is also okay, but you should also mention if there are any pulse deficit. You know what pulse deficit is?
yes.
What? In atrial fibrillation, it's important.
Okay.
What is pulse deficit?
Distal.
Obviously, you don't know.
Uh,
Anybody else? Anybody else in the first year can tell me what is pulse deficit? Come on, all of you have logged in and gone to sleep, is it? There is varying. That means in atrial fibrillation, all the beats are not conducted into form a contraction and form a pulse wave. So the heart rate will be higher than the peripheral pulse that you feel. So that is the pulse deficit. Okay.
okay.
So you calculate by auscultation and then by palpation the differences. Because all pulses are not conducted to the radial artery,
So that's an important finding in atrial fibrillation. Okay.
Inspection, trachea is in midline, apical impulse not visible, no visible pulsation, no dilated vein, LICS scar present and hernial surgery scar present, no other chest wall deformity.
Very good. You are inspected the abdomen as well. Good. Very good.
Palpation, apical beat is felt at left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line, heaving in nature. Systolic thrill palpable in the right upper sternal border, left parasternal heave present, no other thrills or pulsation felt.
When you say the apex beat is lateral to the mid-clavicular line, what does it indicate to you?
It indicates left ventricular hypertrophy.
This is cardiomegaly. Okay.
Cardiomegaly, yes.
Mm.
Auscultation, S1 was normal, S2 was single. And grade 4 by 6 ejection systolic murmur, best heard in the aortic area, radiating to the carotid. I could hear when she was lying down, sir, but it is best heard in sitting and bending forward position at expiration.
Anything else? Anything else you will look for? In auscultation, anything else you will look for?
No other added sound.
Yeah, you must mention there is no aortic regurgitation murmur, because they usually are seen together. Some amount of aortic regurgitation may be present in most of the aortic stenosis
Yes, sir.
patients. So you have to, how do you look for aortic regurgitation murmur?
Sir, in the aortic area, skull rate when we'll get a diastolic murmur.
Yeah, you look for it with the patient sitting up, leaning forward in expiration. That is the best way to see an aortic regurgitation murmur. And again, this always comes to this point of radiation and conduction.
Yes, sir.
When you hear a murmur in the aortic area and you hear the same murmur in the carotid, it's not radiating, it is conducted because it's in the line of the blood flow.
Okay, sir.
Whereas if you hear a murmur in the apex and you hear it in the axilla or in the back, that is radiating.
Okay, sir.
So it's opposite the flow of blood. Okay.
Okay, sir.
When you say an ejection murmur, you should always specify whether you heard ejection click or not. What's the importance of hearing an ejection click?
Sir, if there is any ejection click, the valve is pliable. In case of calcified valve, ejection click is not heard.
That's one. And if the valve is calcified or sclerosed, you don't hear it. Then that's the most important thing to differentiate between a subvalvular stenosis, a valvular stenosis, and a supravalvular aortic stenosis. What are the various features by auscultation you can differentiate between a subvalvular stenosis that may be fibromuscular or it may be HOCM and supravalvular stenosis. What are the clinical findings, difference between these three things?
So by dynamic auscultation, sir, in Valsalva Manual HOCM murmur is better heard in aortic stenosis.
Yeah.
Other systems, respiratory system, air entry, bilateral.
You're not finished yet. See, the click is heard only in aortic valvular stenosis. It's not heard subaortic stenosis and supraaortic stenosis.
Okay.
The other thing is that subaortic stenosis is often associated with mild aortic regurgitation because there's a subaortic membrane. So in most of them, more than 80% of them, an associated aortic regurgitation is heard. But it can occur also in valvular aortic stenosis, a combined aortic stenosis and regurgitation can occur. In supravalvular stenosis, what are the classical signs? Is it a congenital or acquired disease? In whom it's common? It's a common condition in Williams syndrome, supravalvular. And there is olden times cardiologists used to say there's a Coanda effect. Coanda. What is that? Coanda. In rheology or fluid dynamics, there's a rule that high velocity jet, it always sticks onto the lateral side of the aorta, the ascending aorta. So much so, in Williams syndrome and supravalvular aortic stenosis, the right radial is more prominent than the left radial because of the Coanda effect, because the blood coming from the aortic valve keeps on to the right side of the ascending aorta, so much so the illuminate artery pulsation, and the right radial is more prominent than the left radial. That's what the examiners must ask you what is Coanda effect. And the other thing some examiners asked me about this. What is Galloway in murder? Mama. Galloway. Gallvin, Mama. Have you heard of
It is because of the mama radiating to the apex.
what is that? First, specify that.
Systolic Galveridian phenomenon.
Yeah. It's a hollow systolic murmur heard at the apex, almost simulating a mitral regurgitation, but it's not conducted towards the axilla or anything. And of course, echocardiography will prove that such cases will not have mitral regurgitation, but the murmur, hollow systolic, almost simulates a mitral regurgitation.
I see.
There used to be one guy who used to hear it in every case. He's in Australia.
Amit Tripathi.
And sometimes a second sound, because you can find out a lot of things by the second heart sound. It may be single, it may be soft, it may be normally split, it may be reverse split also. In severe aortic stenosis, the second heart sound, if you hear it, may be reversely split. What exactly you mean by reverse split?
So P2 is heard first, followed by A2.
When you auscultate, how do you find it?
So it is heard better in the pulmonary area.
No.
They'll ask them to inspire and then.
Normally, when you take a deep breath, the P2 moves away. And so during at the end of the inspiration, A2, P2 can be differentiated because of the length. In a reverse split, when you auscultate, the resting thing, you hear two sounds. Whereas when you take deep breath, it becomes a single because in aortic stenosis, the left ventricular systole is prolonged, so the closure of the aortic valve comes later on. But when you take a deep breath, the right ventricular volume is low, so the right ventricular systole is also prolonged, so much so the second sound becomes single on deep inspiration. That's how you find out the reverse split. This, of course, surgeons may not bother much about it, but if somebody asks in the exam, cardiologists or cardiac surgeons who are very much interested in cardiology, they will say. So, if it's cleros or classified, you don't hear a second heart sound, it's a single sound. Sometimes it's soft. And then, how do you know from auscultation with a severe aortic stenosis or a moderate or mild stenosis?
So by auscultation, in case of mild aortic stenosis, A2 followed by P2 it is. In case of moderate, single S2. In case of severe aortic stenosis, P2 followed by A2, reverse splitting will be.
Don't forget the duration of the murmur.
Long murmur and late murmur indicate. Late peaking indicates severe.
Late peaking, that's the most important thing to say. Late peaking of the murmur. Okay, can proceed.
Other system, respiratory system, air entry bilaterally equal, no added sounds. CNS, no focal neurological deficit. Parabdomen, soft bowel sounds heard, no organomegaly. Diagnosis, a 60-year-old lady with severe aortic stenosis, probably degenerative etiology in atrial fibrillation, with New York Heart Association class 3 symptom without any features of infective endocarditis, cardiac failure, thromboembolic event.
syncopal attack itself may be a thromboembolic event. Okay.
What a usual
So,
history? What a usual history of aortic stenosis. This is not a presentation. You said this patient has presented with heart failure first. That's not the sequence of presentation in aortic stenosis.
Yes, sir.
Usually examiners ask what is sequence of presentation and what is the life expectancy after each symptom appears. What are the earliest symptom that can occur?
Angina,
Very good, angina. Then,
then dyspnea, and then syncope.
no, that's hard. No, the other way.
Syncope and dyspnea.
Syncope, and then, and God, they will ask you, what is the life expectancy of a patient presenting with angina of
3
syncope
years.
and heart failure?
Life expectancy of patient presented with angina is 3 years and with syncope is 4 years. With dyspnea is 1 year.
Okay, so that's almost correct actually. What's the cause of angina?
It's subendocardial ischemia. Because of increased hypertrophy of the left
Yeah.
ventricle.
This hypertrophy and the oxygen demand and supply.
Demand supply
So-
mismatch.
So, okay. These are some of the usual questions, and you must be ready with the answers.
Sure.
By age-wise, because the most common causes aortic stenosis in our country, maybe one rheumatic, two bicuspid valve becoming stenotic because of that, and the third is degenerative. What is the age sequence for these things?
In rheumatic, they usually present in 3rd to 4th decade.
Yeah. Fourth, actually, fourth. Yeah, 3 to 4 decade. And bicuspid,
Bicuspid in the 5th decade and degenerative in the 6th or the 7th decade.
about 6 actually. Bicuspid usually 50 to 60, and we say degenerative after.
so according to you, this is mild, moderate, severe.
So this is severe aortic stenosis.
Yeah.
Why?
Because the murmur was long in duration in the late peak.
Hmm. And then there's a thrill associated,
Thrill, yes, sir.
and your second sound is single.
Encouraged.
All this
Single-
points to
Severe.
moderate to severe. Hmm.
Yes.
So what are you going to do?
All
Does this patient require any intervention? Does this patient require any treatment, or you can just observe? One. If it requires treatment, what are the investigations that you will do to find out what all things you are going to do in this patient? And second, how do you interpret these results? You tell me in this sequence.
Since
Why do you want to treat this patient?
because she presented with a symptom of syncope. So life expectancy after syncope is 1 year. I would like to treat her.
Okay. So what investigations you will do?
Sir, first I'll take X-ray, ECG, echo, and then according to her age, I'll do a CT angio also.
The life expectancy of syncope is more than that. The life expectancy after the onset of heart failure is only 1 year. whereas the
5, 2, and 1.
Okay. So heart failure is what? You have to treat them if a patient with a pure aortic stenosis has gone into heart failure. And the other things they ask here, because very often we say sudden death, What's the incidence of sudden death?
Find out.
Very often it's
You don't-
overinterpreted. Textbooks nowadays, it's only less than 1% of the patients with aortic stenosis sudden death.
Yes, sir.
Okay.
So you'll investigate her to find out whether she needs surgical treatment or continued medical treatment. And then if surgical treatment, what's the timing? Whether you can wait or we can go on reviewing her. So those are the important things you want to get to your investigation. First, establish diagnosis, then the treatment, and the timing of treatment you have to find out.
What do you expect in our X-ray? What do you think you will see in our X-ray?
Sir, I'll see a left ventricular hypertrophied X-ray. Left ventricular
Is that common?
hypertrophy.
Is that common in pure AS?
No, sir. not
Hypertrophy
common.
is not.
But in our case,
Hypertrophy cannot be seen in X-ray. You want to say whether the cardiac the cancer diameter is increased, usually the LV dilatation. The concentric hypertrophy, actually the heart size will be small, Unless aortic stenosis is associated with aortic regurgitation, the cardiac segment actually is smaller. Right? So don't say you can see hypertrophy. Hypertrophy is usually an ECG sign.
That is the reason why I asked you when the apex beat was lateral to the
Yes.
midclavicular line, there is cardiomegaly.
Okay.
In pure AS, cardiomegaly is not a feature unless it is combined with AR or MR.
yes, sir.
Okay. So in this X-ray, there is cardiomegaly. So you have to look for AR or MR in this patient, which you
Yes, sir.
didn't find clinically.
Yes, sir.
So when you are doing an echo, you must look specifically for that. That's what a clue. Okay.
Okay.
Second, what happens in AS? What happens to the aorta?
So post-stenotic dilatation. So prominent.
There will
aortic.
be post-stenotic dilatation. Is it seen here?
Yes, sir. Prominent aortic knuckle.
No.
Not
Post-stenotic dilatation. Aortic knuckle has no relation to the aortic valve. Aortic knuckle. Why do you think? Why does the aortic knuckle is seen? Where is it seen? The transverse aorta dipping down on the left side of the spine to form the descending aorta, that forms a knuckle. That forms a bend. That is where it is, the aortic knuckle. It has got nothing to do with the ascending aorta. The ascending aorta is seen on the right heart border. Understand?
Yes, sir.
Yeah. So there may be a clue. If you see closely, there may be slight unfolding of the aorta, and the ascending aorta looks prominent because there is a notch in the right heart border. So, and that if you follow it up, it goes along the line to the aortic knuckle. So the ascending aorta seems to be enlarged in this patient, but you have to confirm it with other imaging or echo.
Yes, sir.
So you will look for aortic dilatation. You will look for aortic valve calcification, and you will also look for what the cardiomegaly is due to. These are the three things that this X-ray is giving you a clue. Why do you want to know about calcification? Why do you want to know about ascending aortic dilatation? I think the final years, are there any seniors there? They should be able to tell you. Logeshwaran?
Yes, sir, I'm here, sir.
Yeah. Please tell me what is the importance of ascending aortic dilatation and calcification of the aortic valve? How does it affect your treatment?
If the ascending is very dilated, we have to plan for the ascending replacement also based on the diameters. We have to assess for that. Second thing is if it's a severely calcified valve, we may have a problem in excising the valve, so we have to plan the surgery accordingly.
Okay. And there may be calcium going across onto the annulus. So
And plus-
your annulus size may be constricted. One. Second, what else is importance of calcification in the aortic valve at the annulus? Important preoperatively, you have to discuss this with your patient.
The risk for pacemaker block and
Yes,
then
very good, very good. There may be a heart block in the postoperative period, may be requiring a pacemaker. So that is where this thing. Then of course, in the echo, you will also look for the aortic annulus to see whether the size is good enough for a normal sized aortic valve. Okay. All right. Next. What do you expect in the ECG?
The LV strain pattern.
No, you first say rate, rhythm, P wave,
Rate.
QRS complex, and then T wave, and then the chamber enlargements. That
Yes,
is how you will interpret an ECG.
Yes. 90 beats per minute, sinus rhythm with ventricular premature contraction.
Is that right?
The P waves are seen before the QRS complex.
All P waves, all QRS complex has a P wave.
Yes, sir.
There is varying QRS complex. What does that mean? This is not an ectopic. An ectopic will give you a wide QRS complex. This is AF, control rate probably. There is varying PR interval, right?
Yes,
QRS interval is varying.
Yes, sir.
The classic AF.
Yeah, but P waves are seen, sir. That's why I was
No,
confused.
madam. No, madam. No, madam. The P waves are also not immediately before the QRS. That's also the PR interval is also varying. For example, in the second
Yes, sir.
in lead one, second QRS complex has no P wave there. There's a wider RR interval and there is no P wave there. P wave has come earlier. Don't make this gross mistake. You must know how to differentiate an ectopic from an ectopic. Always has a wide
Okay.
QRS complex. Okay.
Okay, sir.
And ectopics come only in intermittently, not like this.
Okay, sir.
These are narrow complexes. These are varying QR intervals. I mean, varying RR intervals. And this is a classic atrial fibrillation. You can't exactly calculate the P waves in all of them. So if you count them, then there will be they don't follow each P wave should be followed by a QRS complex. It's not happening here. It's not sinus rhythm. Definitely not. Okay, rhythm. Then axis.
Left axis deviation, P1 and P wave.
Doesn't mean anything to me. Why do you need to know the exact axis?
To see the chamber enlargement.
No. Left and right axis does not mean anything to me. You must tell me the number. So many degrees.
-30.
So many degrees because it is of prognostic value. After your surgery, when your LV starts regressing, the axis also regresses, comes back to normal. So as a prognostic value, axis is an important thing. You don't have to do an echo every time. You just do an ECG and then that will tell you whether the patient is improving or not improving, which does not happen in our institution anyway, because patients are lost after 3 months. Then what else? Is there a left ventricular hypertrophy?
The LV strain pattern is seen. Is V1 plus S wave in V1 plus R wave in V5 more than 3.5.
3.5. What is 3.5?
3.5 millivolt, 35 amps.
Tell us the proper standard units. Don't make your own units. Okay?
Yes, sir.
Each small square is 1 mm, isn't it? So it will be 35 mm. What else? Is there a volume overload? This patient has cardiomegaly on X-ray.
Yes, sir.
This patient has cardiomegaly on X-ray. Is there a volume overload?
Yes, sir.
Why? Why do you say so?
In case of LV dysfunction, will get cardiomegaly. In that case, it will be volume overload.
How is it presented on the ECG? We have told you time and again, volume overload, you have a Q wave in the leads, chest leads. And a strain pattern tells you pressure overload. Okay?
Okay, sir.
In AR, you will have a Q wave in the chest leads, which signifies volume overload of the ventricle, and a strain pattern tells you AS, that is the pressure overload.
Okay, sir.
These basic interpretation of X-ray, ECG, and echo must be known to you. Pakka. This is what is being asked to you in your exam. They will not ask you how to do an AVR at your stage. Nobody is going to ask you about operative procedures. They will ask you how to interpret your results. I mean, investigations and decision making. As Sir said, the timing of surgery? When do you decide when to operate on this? Later on, if you're doing well, then they may ask you what type of surgery, what sort of surgery you're going to do, and when and how. That is usually a must-know feature for final year exams. But if you don't know that at this stage, it's okay. But you should know the interpretation of investigations. Okay, next, echo.
Echo impression, very severe aortic stenosis, bicuspid aortic valve. AR mild to moderate.
Put the slide on. Echo.
Why do you think they write so many things there? You have to know each line. You have to interpret each line. You have to assess each line. Just don't tell me the impression. As a surgeon, you must know how to interpret this echo. Impression doesn't mean anything. It is some technician's impression. You are going to be operating on this patient. You must make your own impression. And if you have a doubt, you must talk to your consulting cardiologist. Many a time the consulting cardiologist does not even see this echo. He just signs the report. What are the relevant things that you see on an echo report?
So first, I'll see the morphology of the valve. And
Okay.
in this case, whether it is associated with aortic regurgitation or not, I have to see. Then
Morphology,
ascending
what is the, you said morphology. Tell me the morphology. You have said bicuspid valve,
yes, sir.
right?
Yes, sir.
So it is an abnormal valve to start with. It's a acquired disease or a congenital disease?
Congenital.
Congenital. So she has lived with this valve for 60 years, deformed valve. You remember that? Okay, then
Gradient across the valve in case of stenotic heart disease. Her
okay.
gradient is PG by MG is 156.
In the morphology itself, you have to see something else.
Calcified leaflets and calcification extending into the aortomotor curtain.
Okay, is that there?
Yes, sir.
Okay, then what
Calcified
else?
leaflets.
What else in the morphology important for you as a surgeon? Aortic annulus size, very important
Yes.
when you're doing an AVR.
Yes, sir.
Okay. So if the aortic annulus is small, you cannot, your consultant will not let you do this case for you as a resident. He will do himself. Why? If the annulus is small, this patient may require root widening. To put in a proper size valve to avoid PPM. What is PPM?
Patient prosthetic mismatch.
Yeah. So you must put an adequate size valve for this patient for this BMI.
Yes.
Right?
Yes, sir.
Then what else in the structural morphology? We just discussed this some time ago.
The calcification might go to the conduction system.
That's okay. You said that already. What are the important?
Root enlargement.
Thank you. Aortic root and ascending aorta enlargement. Not aortic root, ascending aorta. Ascending aorta enlargement should be there. What is the size limit? Beyond which size you have to intervene?
More than 4.5. I'm not sure about it.
If you don't know, please go back and read.
Yes.
Is there any of the seniors who will be able to enlighten us?
Yes. If it is a bicuspid aortic valve undergoing AVR, if it is more than 45 mm, we have to replace it. In case of Marfan's 50, in normal letter, it's 55 mm, we have to replace it.
Okay.
It's not correct actually. Marfan's actually, nowadays people say if it's more than 45 millimeter, you have to.
It comes down.
Yes, sir, now it's reduced.
So you should know the latest thing. This measurement that you told us was during our time. Now
Yes.
things have changed. Okay, you must know the latest things.
Yes, sir.
All right.
Yes, sir.
Especially for you 5th years when you are going for your exam. This is important for you.
Yes, sir.
Then what else you want to know? You want to know the LV. Anything about the LV?
LV
Wall
size.
LV size, wall thickness, and end systolic and end diastolic volumes. Yes?
Yes, sir.
So you must tell us those numbers. They have done all that numbers. No, you should tell us those things. And then you should know how to interpret those numbers. What I'm trying to say is don't depend on a cardio technician's impression. You have to make your own impression. You have to interpret the echoes yourselves and then decide on the appropriate treatment. So what are the things that you're interested in the LV dimensions?
LV IDD, LV IDS.
Tell us, no, what is there?
LV IDD is 39 mm, LV IDS is 27 mm. End diastolic volume is 65 and end systolic volume is 26.
Normal or small or more? Is the volumes that you told me, is it normal range? Is it less volume or more volume? If it is less volume, what do you think? What do you think it has? The patient has. If it is more volume, what do you think the patient has?
In diastolic volume is 65, which is less. In systolic volume is 26.
So what does that tell you?
Because of concentric left ventricular hypertrophy test.
How do you confirm that? You must know the thickness of the ventricular muscle. So they would have mentioned there IVS or the free wall thickness. Most people don't write the free wall. They will always write the IVS thickness.
Yes, sir. It is 21 mm.
So normally how much it should be? Should be less than 15, 1.5 or less. So 21 is there is increased. LV, interventricular septum is thickened. So that you presume that the free wall is also thickened. So there is concentric hypertrophy. How does that affect you? How does that affect you as a surgeon? You have a problem with myocardial preservation because there is increased muscle mass. All right?
Yes, sir.
So your cardioplegia delivery has to be pakka, and then your maybe the frequency of delivery and also the volume of the cardioplegia that you give may be a little more than normal.
Okay.
So that makes a difference in your outcome of your surgery. So myocardial preservation will be deranged in this patient. What else you want to know? Very important feature.
About other valves like mitral.
No, you are still in the LV. You want to know if there are any regional wall motion abnormalities, if there has been an incipient MI before. She's 60-year-old.
Yes.
She's got a huge, she's got an aortic stenosis. That may be the cause of angina sometimes. So you must rule out an MI, and you must also know the LV systolic function. How do you know that?
EF, ejection fraction.
Ejection fraction is important. Subsequently, if the patient has gone into failure, you might also have to know the diastolic dysfunction. That becomes a separate thing. But basically, on a screening echo, you will know the EF, you will know regional wall motion abnormalities, you will know the chamber size, right? And the muscle thickness, ventricular muscle wall thickness. So these are the things that you have to see in a patient with AS. And then come to other valves. Tell us about, is there any AR?
Yes, sir. Mild to moderate.
Mild to
Central.
moderate AR. So that is the reason why this patient has cardiomegaly.
Yes, sir.
Is there MR?
MR, mild to moderate.
Mild to moderate MR. So it's a double valve lesion, right?
Yes, sir.
Do you have to do anything for that? Does this patient require a double valve replacement or just an AVR?
But
So clinically you missed an AR, clinically you missed MSMR, right?
yes, sir.
So that is the reason why you have to assess with an echo.
Yes, sir.
And then they've said, I can't see it. I think they've said no RWMA,
Yes, sir. No RWM.
right? Yeah, okay. Tricuspid valve, is it important in this patient? Yes or no? Suganya is there. Suganya, can you tell me whether tricuspid valve is important? She is not there. No, she's gone. None of the other exam going fellows are there. Who are the others? Suganya, Amulya is one, no?
Yes, sir. Suganya ma'am, Amulya ma'am, and Lokeshwaran, sir.
Logeshwaran. That's all? Only 3 of them are appearing this time?
Yes, sir.
Yes, sir.
Okay. You tell me, is tricuspid valve important to see in this patient? If yes, why? If not, why?
Tricuspid valve is usually not affected in aortic stenosis.
You have not been listening all this while, I think. This patient has aortic stenosis, aortic regurgitation, and MR as well on the echo. I don't know if you were awake or listening or not. This is not a patient with AS alone. In a patient with MR, you will be interested in tricuspid or not? Pure MR. Okay, let's not waste time.
Hello, sir.
What other investigations do you want to do, Kritika?
Sir, I'll do a CT angiography, sir.
Why?
To see the coronary, to see whether she has any coronary artery disease first, and to see the coronary origins, coronary sinus origin, ostial origin, and to give cardioplegia.
Very good, very good. Not to give cardioplegia, but if you want to do the AVR or root replacement, whatever, you have to know where the coronary orifices are, because this is a bicuspid valve.
Yes, sir.
They may be not in their normal positions. Very good.
Yes, sir.
Okay. What does the coronary angiogram tell you?
I didn't put that coronary angio in this slide. Anu.
You tell us it's normal, abnormal, whatever it is. We don't want to see the angiogram slide. You can just tell
sir,
us that.
Yeah,
You don't
right dominant coronary circulation and ostium is all arising in the minor CAD in LAD, RC and OM2. No flow limiting coronary artery disease.
Okay.
Yes.
So what do you want to do with this patient? Does this patient require surgery?
Yes, sir.
If yes, what surgery are you going to offer?
Aortic valve replacement.
What about the mitral?
So it's mild to moderate MR.
So what are you going to do? You will reassess this mitral valve on the table with a TEE.
Yes, sir.
Huh?
Yes, sir. Yes, sir.
So you must think, madam.
Yes, sir.
So maybe the mitral valve does not require any intervention right now. You will do an aortic valve replacement. What will you use?
Sir, for her age, bioprosthetic valve.
69. 69 is not old. Okay, all right. Prosthetic valve because she's a lady, she's sedentary life. She's not going to do anything strenuous. Life expectancy, we don't know, another 10 years, 15 years. Although they say 15 years, the manufacturers say 15 years, but hardly it will last that long. What valve, what bioprosthetic valve do we use in our institution?
Magna. Magna
What
East.
Magna? Huh?
Magna East, they are using now, sir, and Hancock also there.
So what are the pros and cons of these models? What type of valve is it? Pericardial or porcine valve? You must know those things.
Yes.
So what are the pros and cons of a porcine valve versus a pericardial valve? Which is better, which is not, which you will choose? These are questions that will be asked. You should go back and find out the answers to these.
Yes,
Talk to your respective consultants. There are some people who prefer a particular type of valve. You must find out why. Some people who may individualize to each patient. You must not ask why. Then you must ask which are the what are the pros and cons of a porcine valve versus a pericardial valve. And then what is the type of valve that you will choose in a patient who has got renal dysfunction? All these things are matter. Understand?
Yes, sir.
Write down these questions, find answers to them.
Okay, sir.
All these questions that I'm asking you you must find answers to them and keep it in your record so that when the examiner asks you you have to come out with your answers.
Yes, sir.
Anything else, sir, you want to add?
Only thing is that when you start presenting an echo, you should tell the examiner that I want an echo and Doppler. So it's very important to do both. It's because there are a few things, from the echo and Doppler, how to differentiate between a severe aortic stenosis, mild aortic stenosis, moderate aortic stenosis by the valve gradient, valve orifice area, the velocity, all those things should come because I don't see any of them here. And the most important, the ejection fraction. So how do you differentiate? Depending on the median gradient, we mainly go by the median gradient rather than the peak systolic gradient. So how do you differentiate between severe, moderate, and mild?
The mean gradient, if it is more than 40, it is severe.
Good.
And 25 to 40 is moderate, less than 25 is mild. Jet velocity
I
mild is
thought
Yes,
usually say 25 to 30 is mild, 30 to 40 is moderate. Above 40, mean gradient is a severe aortic. Okay. Not 25 to 40, that's not a thing. Okay.
Okay.
Then the valve orifice area.
Less than 1 is severe.
Severe.
1 to 1.5 is moderate, more than 1.5.
What is the valve area in respect of the body surface area? That's most important because there may be a huge 80 kilogram fellow and maybe 40 kilogram. So what's the most important thing? by meter square. That's the same thing you calculate for a patient prosthetic mismatch. If it is more than 0.85 centimeters squared, then it's only very mild stenosis. There is no prosthetic. Between 0.85 and 0.65 or 0.6 is a moderate. Less than 0.65 or 6 is a severe. That's how you calculate the patient prosthetic mismatch. Also, depending on the taking consideration of the the patient's body surface area. Okay, not 1.5, 1 and less than 1. So the
Okay, sir.
ejection fraction, not what ejection fraction you expect.
Since it is concentric LVH, ejection fraction is more than what? It will be more.
Normally, we say mitral regurgitation, the ejection fraction you expect about 60, and the end systolic dimension of 40. That's a rule for mitral regurgitation. For aortic regurgitation, it is 50-50.
Okay.
End systolic dimension. And for the aortic stenosis, it's usually 50. And there may be situations where patient's gradient is 30 millimeter. The mean gradient 30 millimeter, but the ejection fraction is only 35. What does that mean?
Low flow, low.
Very good. Low flow, low gradient situation. So in such cases, what can you do?
Huh?
To find out whether it's required operation or not, when there is a low flow, low gradient, less than 30 gradient, and the ejection fraction is 35. This is just a small dose dopamine stress test,
Yes, sir.
And that's how they
Different.
very careful stress test, Hypotension during stress, that's also important factor. So when you say that these things, you ask for an echo Doppler, and you should know. From that, you should be able to decide whether operation is required or not. All these figures you must be thorough with all these figures. The end systolic dimension in each case, and diastolic dimension, the mean gradient. Of course, we used to calculate mainly the peak systolic gradient, but now most people go by the mean gradient. All right. That's very important.
Why not TAVI for this patient?
Sir, she already has an aortic regurgitation patient.
That's okay. Nowadays they do all the things. Not much. You only said mild to moderate. What is your major objection to TAVI?
Calcified ones.
No. They put in severe calcified stenosis as well. They don't care about ppm.
Sir, aortic, ascending aorta dilated.
That has got nothing to do with TAVI. TAVI sits in the aortic annulus. One basic glaring thing, this patient has got a bicuspid valve. It's an abnormal valve to begin with. So the results of TAVI will not be very good in this patient. She'll be better off with a surgical management.
Okay.
Follow?
Yes, sir.
So that is your argument. So you must keep all the factors of your patient in front of you and then talk, not from a book. The patient is in front of you. The investigations are in front of you. That makes you take a proper decision.
Yes, sir.
So if the examiner asks you why not TAVI, you must say, sir, this patient has got a deranged valve, he's got a bicuspid valve, and results of TAVI will not be very good. That's it. The examiner will not ask you another question.
Okay, sir.
Previously, the teaching was, patient above 40 going for the open heart surgery. You do selective coronary angio. Nowadays, you do only CT angio in Narayana Hrudayalaya. Is that right? They don't do selective coronary angio, is it? I just want to know from my knowledge,
So they do coronary angios only on CT. They do so CT CAG once we find, and if we have any lesion that is significant, such as calcium score or LAD showing 50-60%, then they will definitely go on doing the coronary angiogram, conventional. But if CT CAG shows nothing much, we usually don't proceed with the conventional angiogram.
Yeah. CT angio is done more like a screening process. If they
Yes,
find
sir,
an
yes, sir.
abnormality, if they find an abnormality, then they go for a regular angio. Is that right?
Yes, sir. Yes, sir. It's a screening process for everybody more than 35 or 40. It is depending on the consultant's choice.
Okay. Kritika, you have to know everything about the assessment of a patient beforehand, pre-op,
Yes, sir. Yes, sir.
and then interpretation of all the investigations they do. What are the
Yes.
pros and cons of each, and then what is the decision making and the type of surgery that you're going to offer this patient. If
Yes,
you
sir.
do well at this stage, then they may go on to the surgical steps and other things. But some examiners may still go on with that. But basic things you should know. The finer things, the final years should know.
Okay, sir.
This much you must know, Paka. Okay.
Okay, sir.
Any other questions, sir, or any other comments, sir?
No, thanks.
Okay.
Okay, thank you very much. Thank you.
Thank you, sir. Thank you, sir. Thanks.
Thank you, sir.